Welcome. This is the Birth Words Podcast, and you're listening to episode number 18. On this episode, I'm so honored to have as a guest Dr. Rebecca Dekker, the founder of Evidence-Based Birth.
You're listening to the Birth Words Podcast. Utah-based birth doula and applied linguistics scholar Sarah Pixton digs into the language of pregnancy and birth to help expectant women claim their power as life-giving agents engaged in a praiseworthy work. This podcast aims to promote positive birth paradigms and is not intended as medical advice.
Welcome to today's episode. As I said in the introduction, today I'm talking with Dr. Rebecca Dekker. Rebecca Dekker is the founder of Evidence-Based Birth and the author of Babies Are Not Pizzas, They're Born, Not Delivered. Dr. Dekker is the mother of 3 children, ages 5, 7, and 10, and she has earned a bachelor's, master's, and PhD in nursing. She has built a strong reputation in maternal and infant health circles for her pioneering work as the founder of Evidence-Based Birth. The mission of EBB is to raise the quality of childbirth care globally by putting accurate, evidence-based research into the hands of families and communities so that they can make informed, empowered choices. Rebecca, welcome to the Birth Words Podcast. I'm just so excited to talk to you today.
Thank you. I'm so happy to be here, Sarah.
I know from the work that you've done that something that's important to me is also important to you, and that's the way that we talk about birth. So I'm excited to dig into some of these questions I have for you today and hear your perspective about why it's important, the way that we speak when we discuss pregnancy and birth and the postpartum period. So I'll jump into those questions. So for all of our listeners that don't know, Dr. Rebecca Dekker recently published a book called Babies Are Not Pizzas, They're Born, Not Delivered. And the title of that book obviously shows that you feel strongly about some of the terms and the linguistic frameworks that have historically been used to describe the birth process. So I'm wondering, how have your personal experiences changed the way that you feel about the words that we use when we describe birth?
Well, I got my PhD in nursing and was able to get some special training in cognitive behavioral therapy when I was finishing my PhD and afterwards. And since then, I've always been, really in tune to the importance of how we frame things and how we think about things. So when I was pregnant with my second baby, I was trying to avoid a traumatic experience because I had a traumatic birth the first time. And I ended up taking a hypnobabies class at the recommendation of my midwife. And that was probably the first time that I was introduced to the fact that birth language is fraught with many paternalistic terms. And they were the first people to point out to me, although I know it's common knowledge, that babies are not delivered. The birthing person is not the passive recipient of care. Even though it's been framed that way for a long time. And that really opened my eyes. And I began wondering, well, how many other words out there are paternalistic like that, like showing this power differential between the healthcare workers and the birthing person? And I, over the years, have collected, I'm sure you have, the terms, and I actually even used them in a college class that I taught. So I taught a class for honors students and it was called Babies Are Not Pizzas. That's what inspired the title of the book.
That's fun.
And so the college class is called Babies Are Not Pizzas, The Science of How Babies Are Born, Not Delivered. And it was a very popular college class that would fill up within hours of registration opening. And I would always get emails from students afterwards who were disappointed that they couldn't get in the class because it was capped at 20 students. It was a small seminar class. So it was discussion intensive, and they also did a lot of writing and research. And the course description actually was all about the linguistics. So I wanted to read it to you because I thought you might find it interesting.
I'm so excited.
But this is the description that the students read, that's what inspired them to take the class. So it says, the language of childbirth contains many paternalistic terms that indicate the power difference between doctors and pregnant families. The physician delivers the baby. Women are not allowed to eat, drink, or walk during labor. Their labors fail to progress. Their pelvises are insufficient and their babies are too big. And then I talk about how we will use historical readings, current research, and discussions with experts to explore these questions. Where did this medical paradigm of birth come from? Is childbirth a normal life event or an illness? How does midwifery care differ from obstetrical care? What does research support as the safest way to give birth? And what are the human rights and legal rights of birthing families? And the overall objective of this course is for students to discuss the historical, social, and scientific context underlying childbirth in the United States. But I think the fact that I started off that course description with a bang, like listing all of the terms, like really stuck because, you know, a lot of these students, you know, usually they haven't given birth themselves, but they've had family members give birth and they've heard all this stuff. It's like embedded in our culture that babies are too big, you know, labors fail to progress, women's pelvises are insufficient or inadequate. And they're struck by that. And they come to this class really excited and curious to learn about like how this came about. And is it true that our bodies are the ones at fault when labor doesn't go as expected? So it's really fun to frame things around language because people immediately latch onto that because they've heard all those terms.
Yeah.
And if they haven't heard them, when you list them all like that together, you're like, wow, that's pretty heavy, you know, that's pretty negative way of framing birth. So so that's kind of where I got started, and where I really got into is when I would sit in the college classroom and hash out these topics and these phrases with the students, and just really over time grew to love the babies are not pizzas phrase. You know, it's on t-shirts and that we sell. And when my husband, he always gets comments because he's a tall guy. So when he wears this bright maroon shirt that says babies are not pizzas, they're born not delivered, like everywhere he goes, people just like, they read it and they look really confused, and then they get to the punchline, they're born not delivered, and they always start smiling and laughing. And I mean, I don't care where we are, if it's the mall, fast food, a gas station, the airport, wherever we are, you know, if we're wearing those shirts, we get comments on it because it's, I think, a universal theme. And people are like, oh yeah, you're right. Like they are born, they're not delivered from us. So yeah.
Yeah. Wow. Okay. I have so many thoughts in response to that. But one, the main one is that I wish I could go back in time and over to Kentucky when you're teaching that class, because I would have loved to have been a student in that class and have those discussions with you. I think it's so important that you're having those discussions. And I do think that it's really problematic that these frameworks, even people who don't inherently actually agree with the assumptions that lay underneath using the word delivery, using the word failure to progress. Like we use them because they're so embedded in our culture, and then we're just making that language go forward, and it's disempowering, and it does, frame the birth giver as a recipient of care, like a passive recipient of care rather than an active life-giving agent. So I think that's huge. Thank you for all of your work with that. No, go ahead.
Well, I was just going to say my brother-in-law has his PhD in history, and he likes to argue with me about the phrase delivery. Yeah, because he says, like, historically, it was kind of like you were delivered of, or you delivered your own baby, but you were delivered of your child in almost like a life-giving, life-saving sense, because so many people used to die in childbirth. And so he doesn't have a problem with the phrase because he looks at it more in terms of its like ancient or historical sense. And what I always argue with him is, maybe that's what it used to mean in the past. But today it's acquired a secondary meaning when you say they delivered me, meaning that I laid back and the doctor did the work. So that's kind of what we want to avoid, is that connotation.
For sure. I actually have the same conversation with my husband, and he takes that historical perspective. And I agree that it's problematic in that we're saying the doctor delivered me or delivered my baby. And yeah, interesting. Okay. So as you've found these various problematic paternalistic words, phrases, and linguistic frameworks, what do you feel like was the defining feature that united?
A couple uniting features. I think one is control over bodies, and control by putting the power in the hands of the practitioner or clinician, and also control by labeling the pregnant birthing body as being the failure or the problem.
Yeah.
So I do think it's a matter of power is what unites those words, because it keeps the clinician in the position of ultimate power to make all the decisions. And it keeps the person who's birthing the baby as the bottom of the power, because their body's the body that can fail or be inadequate or insufficient. So I think it's probably power is what ties everything together.
Yeah, I have to absolutely agree. And the work that I've been doing as well, I definitely see the themes of power and control coming up over and over again and being problematic in a lot of instances. So from your perspective, what's the defining feature that unites preferred words, phrases, frameworks?
It's the same feature, probably power.
Right. Exactly, but we preferred it. Right?
Right, putting the locus of control back with the person whose body is doing this amazing thing and whose body may need support or assistance, but they're the one doing it, growing this baby and bringing this baby into the world. So when I see things like, when I hear people say things like, I gave birth, or I did it, or I needed help, I needed a surgery, but I felt really good and empowered and strong about my decisions and about how I spoke up for myself. So I kind of see it's again, it comes back to power. Like, who is the power line? Are we trying to take power away from people? Are we disempowering the family and telling them that the clinician's in charge and the clinician makes the decisions? Or are we putting the power with the people who will be raising this child and, be responsible for bringing this child up into adulthood? So to me, it all comes back to power again.
Yeah, and I think you make a good point about putting the power in the hands of those that are going to be responsible for raising this child, because to be in such a disempowered state at like the onset of parenthood is really tricky. Like, it is a difficult way to begin navigating that really difficult path of raising a child if you began it lying flat on your back, being told when to push, when to do this and that, and treated as a patient that is passive, and then to turn around and take that baby home and try to figure out how to teach it and raise it and help it to grow it's really a problematic system, I think.
Exactly.
There was another thing I wanted to comment on. Something that's come up recently in my conversations along these topics with birth workers is the concept of informed consent, right? Lots of birth workers say informed consent is my jam. Like, informed consent is what it's all about, because there is a problem that so often things happen to a birth giver without their consent. But even so, like, I think it's ironic and disheartening that we're fighting for informed consent when consent means like that you concede, that you kind of allow something to happen to you rather than being an informed decision maker, making informed choices. So I think we have even another step to go in that framework. Does that ring true with your work and your experiences?
Yeah, I agree. Definitely can see that.
Along those lines, I know one topic you said that you're interested in is vaginal exams and the language that surrounds those. Is there anything you wanted to comment on relating to vaginal exams, informed choice, informed consent? Yeah,
I think vaginal exams are really interesting to me because I had the experience with my first birth was, it was assumed that I would have a lot of vaginal exams, even though my waters had broken. And so every time they did one, they were increasing my risk of infection. Whereas with my second birth, that became really important because I felt, to me, the vaginal exams were very painful and I didn't want to be distracted by hearing about the results.
Mm-hmm.
So I was able to give birth the second time without so much as even a single vaginal exam, which was normal for my home birth midwife. She would use other ways of determining how far along her clients were in labor, including things like the purple line, which a lot of hospital clinicians never see because most women are laying in bed on their back or covered up with a gown. But she also uses behavioral cues to determine where you are in labor. And I was able to push my baby out and, without ever being checked one time. And it was interesting to me that in the hospital setting that check is essential. It's critical. And even if you have on your birth plan that you don't want multiple checks or you don't want unnecessary checks, it kind of assumes that you will at least have one check when you arrive to make sure that you can stay there, that you'll be allowed to be admitted there. Doesn't matter how frequently your contractions are happening, how your behavior shows that you're definitely in active labor. If you don't have that exam, they won't admit you. And to me, that shows an immense amount of control taking over the birth giver's body, that you could require them to have a vaginal exam in order to receive care. Like it's this transaction. And it's also interesting how culturally, how hospital staff members don't realize, they haven't been exposed to birth where there were no vaginal exams. So to them, it seems crazy and impossible to give birth without a vaginal exam. But I'm here to tell you, it can be done. Like I was able to do it. And I'm not saying that there isn't a place for it, because with my third birth, which I talk about in my book, Babies Are Not Pizzas, I actually got a vaginal exam at the very end because I was getting very tired. And my midwife was like, can we see if you're ready to push? Because it's getting really late and you're really tired. And she checked and the baby was like coming out. She's like, the head is right there. Like you push a couple of times, this baby will be out. And I didn't, but if she hadn't checked me, I probably would have had that baby in the next few minutes anyway. So, but to me, it's, it also came up with, I have a good friend, Kristen Pascucci, who I talk about in my book, Babies Are Not Pizzas, and she runs the website Birth Monopoly. And she sat through 2 weeks of a trial. This was like a court case, a jury case against a hospital in Alabama where the nurses had physically wrestled a woman to her back during labor. And I remember reading the court transcript and like talking with Kristen about the trial, and they talked about how the defense attorney for the hospital was telling the jury, now you're going to hear some words during this testimony that might seem funny, but you're going to hear things like vag check. And the jury had to be told what that meant. But a vag check is a vaginal exam, and it's how the lingo the staff uses when they talk about examining a woman's vagina. I'm going to do a vag check on the client in room 102, or I need to go do that vag check. And what it does is it reduces the birthing person down to a procedure in kind of this disembodied birth canal. Like, it's not like they don't think of the person having this vaginal exam as being a human being who may or may not have a history of sexual assault. It's just, I got to go in and stick my fingers in there and check to see how dilated they are. It's become so, the staff are so desensitized to what they're doing that even their language reflects, that I'm going to go do a vag check. There's no, I'm going to see if she needs one. I'm going to see if they want one. It's, I'm going to go do it. And it's not being done to a person. It's being done to a patient. And it's being done to kind of like this disembodied part of their body. And to me, that's just really scary when you consider, and how that's such a lack of trauma-informed care when you consider that, at least 1 out of every 4 women has been raped, and more than that have been sexually assaulted or abused. So it's harmful to treat vaginas like they're this task to be done and to be charted on the whiteboard at the nurse's station. And it all goes back to control and power. And who has the power in those situations? It's the clinician, it's the hospital staff member. It's not the person whose body, this part is a sexual organ belongs to. So that's one reason, when you reached out to me, I was like, I want to talk about vaginal exams, because it's just become an area that is desensitized among clinicians, and they need to have greater respect and understanding for. And I wish more hospital staff could observe home births and freestanding birth center births where vaginal exams don't happen at all, so that they can see that it's not an essential. It's a tool. It can be useful in certain situations, but it's not required at every birth. And it certainly shouldn't be done without the birthing person giving their explicit, freely given consent to do it.
Yeah. Wow. Thank you. I really so appreciate all the thoughts that you've shared during this brief call. I'm going to wrap up with one last question for you. If you had to choose just one word to describe your feelings and beliefs about birth, what word would it be?
Oh, I think I would just pick the word power.
Yeah.
Because we can be really powerful when giving birth. And it's empowering and powerful for clinicians and healthcare providers when they see people giving birth on their own terms. So it's just an amazing, powerful experience for everyone in the room.
Yeah. Thank you so much. And those of you who are listening, you can follow Dr. Rebecca Dekker. You can sign up for her newsletter at the homepage at the bottom of evidencebasedbirth.com. You can follow EBB on Facebook, search for Evidence-Based Birth, and on Instagram at EBBirth. And her book, Babies Are Not Pizzas, is available on Amazon. Do you want to add anything to that?
Oh, no, that's great. Thank you so much for having me, Sarah.
It was excellent. Thank you so much for sharing your expertise with us. I really appreciate it.
You're welcome.
Did words play an important role in your birth experience? If you're interested in sharing your story on the podcast, go to www.birthwords.com. If you're liking what you hear on the podcast, please leave a review on your podcast app. For more resources about harnessing the power of words to benefit the birth experience, visit birthwords.com.